their patients, certainly in comparison to what standard Holter monitoring has been able to provide. In that context, it is not therefore surprising that there's a dizzying array of ECG monitoring tools that are now available, ranging from spot single-lead ECG checks, now popularized by smartphone-based technologies, to standard Holter monitoring, which has given way to extended duration Holter monitoring, of course, mobile telemetry systems, and then there is implantable loop recorders, and certainly excluding patients with implantable pacemakers and defibrillators. And this therefore raises the question as to how do we then go about choosing the optimal ECG monitoring technology in our given patient. So I thought we'd do that in the context of just some two common use case scenarios that we see in clinical practice. So this is a patient of mine, 50-year-old female with hypertension and Sjogren's syndrome, complains of palpitations, episodes occurring intermittently, last a few minutes, no ECG documented episode, baseline ECG and echocardiogram are normal, and she presents for further evaluation in the context that she has a CHA2DS2-VASc score of 2, should she have documented atrial fibrillation. In patients like this, I think certainly smartphone-based diagnostics have changed the game completely. These devices are cheap, they're owned by the patient, they're real-time, they're long-term, provide very high-fidelity tracings, and importantly, no intermediary between the patient and the doctor. And I think one of the really important things to emphasize is that they give real-time information to patients. And I think that we have to ask ourselves, how much longer are we going to keep employing patches and monitors on patients that do not allow patients to see in real time what is happening with their heart rhythm? And as wearables and these types of technologies proliferate, I think the patient acceptance for those blind box-based technologies will become less and less. Not surprisingly, during a representative episode a few months later, the patient has easily diagnosed atrial fibrillation. And the other notion that's out there that these devices are used to screen and then need a confirmation with a standard medical grade technology is also very hard to believe. I think there's few people who would have difficulty making a concrete diagnosis of atrial fibrillation based on this tracing alone. So if we think about the potential applications of this technology, well, you can certainly diagnose unexplained palpitations. In patients with paroxysmal atrial fibrillation, you can easily assess heart rates in sinus rhythm versus AFib. You can assess the relationship between symptoms and recurrences of atrial fibrillation in patients treated with drugs and ablation. And importantly, in patients with persistent atrial fibrillation, just daily, once-a-day objective self-monitoring allows you to exclude, by definition, the phenotype of recurrent persistent atrial fibrillation. Now let's look at a second case use scenario. So here's a 74-year-old male with hypertension, remote history of SVT ablation. A year and a half ago, he had a stress test. He was able to exercise 6.5 minutes on a cruise, no problems. He recently noted that his heart rate was elevated when he was at the gym. Really no specific symptoms referable to the heart rate. ECG demonstrates AFib with rapid response, and echo shows a significant diminution in LV function, which is new, and he's referred for further evaluation, and an EKG at the time of presentation shows that he's in sinus rhythm. And this is the kind of patient now you want to possibly understand more in terms of what's going on with the atrial fibrillation, what the burden of atrial fibrillation may be. And as good as wearables may be, it's hard to believe in the near future that you're going to be able to counsel patients to walk out of your office and go to the Apple store to buy a $500 watch as the first line of therapy. In patients like this, I think extended Holter monitoring has been a useful option. This is relatively cheap compared to real-time monitoring. And in this patient, we're able to quickly establish and confirm the phenotype and establish a high burden of atrial fibrillation in these patients. Now, in the last session, this is a word I think there were several commentators who commented that the phenotype of patients is dead. But I would say that before we kill the phenotype, we should at least establish that we're very imprecise as clinicians in being actually be able to phenotype the patients accurately in the first place. And before we kill the concept of phenotype, we should at least standardize our understanding of how people are phenotyped before inclusion in clinical trials. The shift of burden is clearly there. We heard it from Nasir and others with respect to CASTLE-AF yesterday. The KP Rhythm study very nicely showed that the stroke risk was inherent to how much burden of atrial fibrillation was. In this study, patients with the highest burden of atrial fibrillation, in this case greater than 11%, seem to have the highest risk of stroke, as shown here, that even after adjusting for their underlying CHADS vascular atria score, it was the patients with the highest burden of atrial fibrillation that appeared to be at high risk of stroke. So if burden is important, certainly in patients like this, it stands to reason that population-based endeavors will try to identify high-risk patients based on their underlying burden of atrial fibrillation. MSTOP, a unique study between a pharmaceutical, a healthcare provider, and a healthcare system, looked at the role of extended monitoring with a patch-based recorder and showed very nicely that this was a superior strategy to picking up atrial fibrillation compared to a clinical strategy alone. But if you look at the burden curves, most of these patients had relatively low burden of atrial fibrillation. So if 1 or 2 weeks of monitoring are good, then it stands to reason that even longer term monitoring should be even better. And that's where this notion of wearables really starts to shine, because it's certainly going to be difficult to employ medical grade technologies on a widespread basis if you're trying to identify potentially high risk asymptomatic individuals. So 2008 probably marked the era of smartwatches for AFib. I will quickly go through 3 studies that have been published in the last year. And really, while they looked at the 3 different concepts, the basic conclusions are very similar. And they are that while the technology has come a long way, there are still gaps in the ability of these technologies to accurately classify atrial fibrillation for each and every episode. So this is Khaldoon's study that he presented yesterday of patients using a smartwatch in a cardioversion population. And importantly, the real key thing is that the app-based algorithm, that albeit a first generation look at this, could only diagnose atrial fibrillation in 66% of patients presenting in AFib for cardioversion. But if it could diagnose it or could read the EKG appropriately, then the accuracy of this reading was very high. Similar findings from this second study, looking at the use of a smartwatch photoplethysmography coupled with a deep neural network, again showing that if you take a select cohort of cardioversion patients, the technology performs very well, but of course we still have a little bit of work to do as we move to a larger group of ambulatory patients. And more recently, this week's JACC-EP is this study, the WATCH-AF trial, where they took a population of 672 patients who did or did not have atrial fibrillation. All patients underwent an ECG using a smartphone-based app and also wore a watch capable of the same PPG technology. And again, the important thing to point out is that in just about 22% of patients, the watch was incapable of classifying the correct rhythm. But if you could get beyond that point, a very high specificity and positive predictive value, which should allay the concerns of those who are concerned that this type of technology will open the floodgates for false positive diagnoses. Now, in comparison, we have loop recorders. Loop recorders, as we know, perform very, very well, certainly when AF episodes are greater than an hour, but still it's important to recognize remain challenged when it comes to atrial fibrillation burden because they don't do a very good job handling atrial and ventricular ectopy as well as atrial tachycardia. 1 hour seems to be an important cut point, at least in Rod Passman's study and several other pilot studies showing that if you're going to try to use these as a pill-in-the-pocket anticoagulation strategy, if you could diagnose down to 1 hour accurately, they may be rational for using these devices. So as we summarize, what ECG for which monitor? Well, if you look at the different use case scenarios, you have a cryptogenic stroke patient. Well, the ILRs may do pretty well for as long as the episodes are greater than an hour, but it may be possible that if we need longer episodes to really be significant, then it stands to reason maybe smartwatches may be perfectly fine in these patients. In patients with establishing AF patterns, well, again, once a day ECG check done consecutively over many days can easily establish AF pattern. Certainly for assessing efficacy in the context of a clinical trial, probably an implantable device stands the best. And of course, this holy grail of pill-in-the-pocket anticoagulation is really the concept of how far can we push these technologies, and there the jury remains out. Now, I'll conclude by showing this slide, and that is that when we look at our overall population, we have these groups of patients: general patients, high-risk symptomatic patients, and ongoing management patients. And traditionally, we as clinicians have focused on the bottom bucket, these patients in whom we're trying to manage AF, manage post-ischemic stroke, and we've applied medical-grade technologies to these patients. The wearable companies have been much smarter because they don't care about that population. They've flooded the market for the general population. And I think the challenge we're seeing is we're trying to take that technology and really push it to its limits and trying to employ it in high-risk asymptomatic patients, symptomatic patients, and even more, trying to use them for ongoing management of our AF and ischemic stroke patients. And that's where the jury remains out, and that's where the technology needs to improve so that we can find a common ground of picking the right technology for the right patient. Thank you very much for your time.